Welcome to AETCM, the emergency medicine channel. 50-year-old male presented to ER with sudden onset occipital headache radiating to neck since few hours. On initial 10-second assessment, patient conscious oriented, obeying commands, airway is patent, no pooling of secretions, breathing, saturation is 100% on room air, respiratory rate is 16 per minute, air entry bilaterally equal, circulation BP 170/90 millimeters of mercury, pulse rate was 80 per minute, disability GCS was E4 V5 M6, pupils bilaterally equal and reacting to light, exposure febrile, patient is febrile, GRBS is 100 milligram percentage, and the pain score was 8/10, and we have given injection PCM 1 gram IV stat at the spot. And on again reassessment, pain score was still 8/10, so we had given injection tramadol 50 mg and injection NSAID 4 mg IV stat. Coming to sample history, 50-year-old male who is a known case of hypertension but not on any medication and with history of binge alcohol drinking, presented to ER with complaints of sudden onset occipital headache radiating to neck since few hours. Pain was severe in nature, throbbing type, and had taken paracetamol from home but was not relieving. No history of any vomiting, photophobia, fever or head injuries. No history of any weakness of limbs, slurring of speech, loss of consciousness and seizures. No similar history in the past. On examination.
Okay, just wait. So, we have a 50-year-old male who is in hypertensive and he had a binge alcohol consumption and he has come to the ED with a history of headache. So, few things more we wanted to know. Any previous history of headache? No. This is the first time he is having his headache like this. Okay. And next important thing, what was the severity of the headache? You said it is 8/10. Even after an analgesic, it is not relieving. So, see, from the history, it is clear cut for it is a subarachnoid hemorrhage. We need to rule out. That is very clear. So, worst headache of the lifetime is coming to the ED with this. So, in presentation, so what is your most important consideration when you suspect a subarachnoid hemorrhage? Is the severity of the headache or the acute onset of headache? Which one you will take it as more important? See, you can get a patient with migraine, he is coming and telling you that he has got very bad headache. It is the severity of headache that he is complaining. And there is another patient who has come to you similarly, sudden onset of headache. He is not able to say it is a worst headache of his lifetime, and severity wise his pain score is a little bit on the higher side. So when you consider SAH, which is the priority? Subarachnoid hemorrhage with an acute onset, or you suspect a subarachnoid hemorrhage with the severity? What is the most important?
Acute onset.
It is the acute onset. That is the most important catchy thing in this. So it is an acute onset. In migraine headache and all, it will be sometimes the migraine patients, they will come to us. They will come to us and say, this is the worst headache that I never had this sort of headache. But it is never an acute onset. Say they will have an aura, they will have slow worsening of the symptoms, then you have additional photophobia, and they will come to us. And when you suspect an acute subarachnoid hemorrhage, first onset headache, acute onset. So that is the most important catch that you want to take in this. You will be able to get a worst headache, although history might be, but whenever you say an acute onset headache, you should give differential diagnosis as subarachnoid hemorrhage. So that is the first thing. Then what are the other reasons when we suspected subarachnoid hemorrhage in this patient? One was acute onset, and the second one is radiation of the pain to the occipital region and to the back and to the neck. So that is again classical of subarachnoid hemorrhage. And what are the other things that you say, okay, this is possibly a subarachnoid hemorrhage, not an intraparenchymal hemorrhage or any other type of a CNS emergencies. I'm not discussing in terms of a migraine or a trigeminal neurology or a tension headache, not all those things. I'm just taking when you have to suspect a subarachnoid hemorrhage, why you say it is a possibly a subarachnoid hemorrhage. One, you said this, then second one, radiation, then third possibility,
no focal neurological
deficits. No focal neural deficit. That is the most important thing. Majority of the subarachnoid hemorrhage, they will not have any of the focal neurological deficits. They will be completely preserved. Their GCS may be full. Only 50% of them, their GCS may be full. There will not be any deficits also. So that is the next important thing that, okay, possibly we are suspecting this. Then what could be the other reasons It can be attributable to others also, but it can be a possibility here also. What are the other reasons?
Comorbid conditions.
Comorbid condition. What are the risk factors of subarachnoid hemorrhage? Most common risk factors. Hypertension and alcoholism. So these are the two: smoking, alcoholism, and hypertension. So these are the three major risk factors for subarachnoid hemorrhage. In this, you have already two risk factors. And other thing is that the pain severity is also here. It's on a higher side. Even after consuming, giving one analgesic, the pain is not subsiding. So this all with this attributing, probably you're dealing with a subarachnoid hemorrhage. There is no doubt in this. So how will you suspect if the patient never had any of the symptoms? So which group of patients you will, okay, I need a CT scan for this patient. When you will ask for a CT scan for a patient that is coming to headache into the ED?
If age is more than 40 years,
okay,
then any neck stiffness or neck pain.
See, rather than saying it in that way, which all patients you will definitely ask for a CT scan? This patient I will definitely ask, 100%, irrespective of the age.
Low GCS.
Definitely, sensorium. GCS is on anywhere below the normal, then any seizure at the onset of symptoms, any focal neurology deficit during that, definitely you will take. Then the patient have persistent evidence of raised ICP. The patient have persistent evidence of raised ICP in terms of either an hypertension with bradycardia, or you have seeing any pupillary, major pupillary asymmetry, or patient have multiple episode of vomiting. See, you can say 2 episode of vomiting is okay, 3 episode of vomiting is okay. We cannot predict that way. These are all guidelines they are saying. But whenever you have suspicion of other things together, you need to take probably an CT imaging. So what will be the classical history that you will get in migraine after vomiting? The pain will subside. So when the pain is subsiding after vomiting, then you can think, okay, it is a probable migraine. Maybe you can treat them with other modalities and see how the patient is responding. Maybe a dose of triptans during the acute phase is relieving their symptom. That gives a clue that probably we are doing a migraine, and previous episode is there, aura is there. All the things together, we can. One of the commonest thing that we see is migraine versus, that is where we find it difficult to find it out. Okay, so after this, an age group. So again, age group again is very key. When you think in terms of an intracerebral hemorrhage or anything, it will be like extremes of little bit extreme of age, like maybe 60s. You cannot have, I'm not saying that it is a maximum incidence is during this age group. And when you see subarachnoid hemorrhage, it is mostly in the 3rd, 4th decade, 3rd, 4th or 5th decade. That's a usual presentation. He is into 50 years. So maybe anywhere between 30 to 50 years of age, that will be the presentation. So all these things put together into the boxes, you are suspecting an subarachnoid hemorrhage. Any scoring system that you can use of thinking in terms of subarachnoid hemorrhage, don't use it. That's what I am going to tell. Don't use it. Scoring system should not be used. There are a lot of scoring system. You can tell that you are taking a CT scan, but that will never say that you need not have a CT scan. Rather than you go clinically, there are n number of scoring systems for this. But subarachnoid hemorrhage is one area where we cannot miss it. So one area like just our pulmonary embolism, why we are relucting is that whether the patient needed to go for a contrast study. So here is a plain CT. You can have a suspicion, it's easily available, go ahead and rule out a subarachnoid hemorrhage. So don't tell that the scores are negative and I didn't do a CT scan. So that is one area that they found in evidences that don't use scoring system in case of diagnosing a subarachnoid hemorrhage and even referral to a neurosurgeon. So like this, it's just a mild hemorrhage, I will keep him in my ED. He need not be referred to a neurospecialist. So these are the two things that you should not be using, but you can try and keep it in documented, but preferably don't use the scoring system. Even if you are using, usually if you have done for this patient, it will have been on the higher side only. So that is what you have to, now the idea is that you have to, what are the challenges that you have? A, B, C, D, E challenges in this patient. We don't have anything at present. Airway was patent. So GCS was full. So breathing was fine. Circulation, only concern is the hypertension. What was the blood pressure?
170/90.
So target is less than 160/90. So little bit on the higher side. Unless and until you have not diagnosed a subarachnoid hemorrhage, I would not have jumped and started treating this BP. Maybe I would have given some analgesic and waited for this. Once I confirm that it's a subarachnoid hemorrhage, I need to control the blood pressure. So till that time, maybe you can just wait and see how the patient is responding. Maybe after the first dose of analgesic, the patient will improve. But here the patient's symptoms have not improved. You have given another analgesic. That itself shows the severity of the disease. So from this point, definitely the next investigation within the next 20 or 30 minutes, the patient should be ED. He should be in the CT room. What was the CT done?
CT brain showing subarachnoid hemorrhage involving basal cisterns, brainstem cisterns, and bilateral sylvian fissures.
Okay.
So we had started managing his injection labetalol 10 mg IV stat was given, and head and elevation to 30 to 45 degrees. Antiemetics were given and BP monitoring was done and half hourly. Then injection 3% saline at 20 ml per hour was started as a prophylactic method. And we also started with tab nimodipine 60 mg every fourth hour.
Now we will just cut down each of the things whatever you have said. You said you will keep the patient on a propped up position. That's the first thing. So what is the reason why you want to keep the patient in a propped up position? And you said you want to give labetalol. So you can tell the reason behind giving all those things. So first propped up position.
Head elevation is to reduce the edema, weakness out edema further.
Okay.
Then injection 3% saline also the similar.
Okay, so 3% saline, the target sodium you should be checking 6th hourly, and the target is somewhere around the higher than normal. 145, if you are taking it as 145, somewhere around 140, 145. So usually 20 ml per hour you will start off and you need to monitor the serum sodium levels. We are not treating for hyponatremia. So next thing.
Then labetalol.
Labetalol you wanted to give for the blood pressure control. That's what I said to you. The target is less than 160 by 90. Then
nimodipine central to increase vasodilation, to decrease the central vasospasm.
Okay, so you think that one of the complications for developing for subarachnoid hemorrhage are two. One is rebleeding, and second one is an vasospasm, which can happen around to 15 to 20% of the people with aneurysmal bleed especially. So those group of patients, you can nimodipine is found to be beneficial. You need to give 60 mg 4th hourly. So that is the dosing. So these are the reasons why you have given. So a reasonable treatment that you have given. Suppose imagine that the CT was negative. CT is negative, but I am telling you this patient is a higher risk case of subarachnoid hemorrhage. CT's initial CT you have taken is negative. So what will you do next?
We will manage the BP and we will repeat the CT after.
No.
So.
Okay, see, imagine that what are the recommendations you should know. One thing is that if the patient has got a symptom onset and initially within 6 hours you have taken a CT and it is negative, then the next option is that you can wait for another 6 hours. Or meanwhile, if you have done definitive CT, aneurysmal bleed is only a very minimal percentage of the bleed that is going to happen with your subarachnoid hemorrhage. Majority of the time, you don't know why the patient is happening in this. And there is a possibility of venous hemorrhage also. 15%, we always think of aneurysmal arterial bleeds. So there are around perimesencephalic bleeds and all. That is actually venous bleeds. So venous bleed, maybe this patient is having a venous bleed. It will be more in the cisterns, midbrain, that region. It will be the most commonly seen. So it is a mesencephalic bleed, maybe to the hypertension and maybe to the alcohol that you have consumed, the blood pressure has gone up, and we had a patient who had an subarachnoid hemorrhage, again venous and post-coital. He just had a post-coitus and he just came with this very bad headache. So just after an hour he came with a headache and it was a subarachnoid hemorrhage. So the amount of sudden gush of blood pressure and stress can cause this. So why an aneurysm develops? Where you get an aneurysm develop? Why an aneurysm develop inside the brain? What is the pathophysiology behind that? Where is commonly the aneurysm seen? Anterior communicating artery, and wherever there is a communication, wherever there is a bifurcation or division, that is the area where the shear pressure increases because of the flow. So that is the regions where you will get all this aneurysm being formed. So when the aneurysm is formed, you see, we are seeing only a very tip of the iceberg. Those are coming with an aneurysm bleed only. Maybe you evaluate the room itself, we have 6 of us sitting here. If you are evaluating us, one of them can have an aneurysm which is asymptomatic and that is not causing any problem. So that aneurysm, some persons only will go into an hemorrhage sort of a situation. That is what has happened. Maybe if not for this patient, maybe for another patient, a very small percentage can be an aneurysmal bleed, and next can be an non-aneurysmal bleed where we don't know what is the reason, and very, very rarely we can have AV malformations. So these are the 3 reasons why you can have a bleed, and around 15% of this thing, this is perimesencephalic bleed. That is what we said. Around the midbrain and the cisterns, they will have the hemorrhage. So it's classically an hemorrhage and venous hemorrhage. And the good thing about this is that when you overall look into subarachnoid hemorrhage, the mortality is around 50%. And the other recovering patient, they can have significant morbidity also. That is again 20 to 30% of the group of patient. But when we look into perimesencephalic bleed alone, they have got very good recovery. So that is the advantage of knowing why it is a perimesencephalic bleed. And if you are not getting anything in the CT angio, or if you are not getting anything else, that is what I have been asking you. What is the next investigation that you need to look in for? The next investigation that you need to do, ideally a recommendation is a lumbar study, lumbar puncture. So lumbar puncture, when you should perform a lumbar puncture? Xanthochromasia, you have to look for the ideally a spectromicroscopy, that is the ideal. So after 12 hours of the symptom onset, that is the initial recommendation. Because what we looking into? We are not looking into the RBC. We are looking into the RBC breakdown. When you are looking initially, that hemorrhage itself will come and we can get a false report sometimes. But what you need to do, you need to wait for 12 hours. Keep the patient in the observation. If you suspect a high, ideal recommendation, these are all guidelines what I am saying, but majority of the time initial CT you will pick up. But if you are going for a competitive exam, the initial CT is negative, you don't go for a next CT. After 12 hours of symptom onset, you go for a lumbar study and look for xanthochromia in the CSF. So that is the recommendation, general recommendation for suspected subarachnoid hemorrhage. Then as you said, like CT angiogram, you can go for MR angiogram for looking for the diagnostic. But majority of the time, all these tests can be negative from the bleed type that you are saying here. So what was done for this patient?
CT angiogram was done. Subarachnoid hemorrhage involving interpeduncular cisterns, supercellular cistern, lamina terminalis cistern, bilateral sylvian cistern, right ambient cistern, and bilateral crural cisterns. Basilar artery is mildly attenuated in caliber, however patent. No evidence of flow-limiting placo-stenosis, no evidence of aneurysm or dissection.
Okay. So don't see anything, aneurysm, dissection, nothing was seen. So probably we are dealing with a mesenchymal, perimesenchymal hemorrhage or a venous hemorrhage. That's what we have been discussing. So that is why you see his sensorium is preserved. He's having a full score. So, and he don't have any neurological deficit. So what are the complications that you will anticipate in a subarachnoid hemorrhage? It's easy, no?
Rebleed can happen.
Okay. See, complications can be of two types. Subarachnoid hemorrhage as such, and due to subarachnoid hemorrhage, you can have certain complications. So subarachnoid hemorrhage as such complications is rebleeding and vasospasm that we have already discussed. What are the issues that this subarachnoid hemorrhage can cause?
If increased
Why there is headache? Because of the meningism. Next.
And can be angle herniation can be done.
So herniation and worsening, hydrocephalus. Much before that you have to think, because it's all in the cisterns, it can cause hydrocephalus. So then cranial nerve involvement. It all depends upon where exactly the bleed is. So we can come with the patient with ptosis, ophthalmoplegia, all those things, cranial nerve involvement. The patient can present with a cranial nerve involvement. Very important, you need to look into that. Then next, what are the other complications? Like you said, raised ICP, anything of raised ICP, angle herniation, all those things. And that are the usual complication, pressure related complication that the patients can have. So our idea is what? Our idea is to suspect, diagnose and do the initial treatment. The final treatment will depend upon what the etiology is all about, what is the reason behind the bleed. Here there is no aneurysm. If it is an aneurysm bleeding, it is an endovascular therapy treatment is the treatment of choice with the coiling or maybe clipping. But now the coiling intervention radiology is much more into this. So more often we will go for that. And rest important thing is that how you need to observe this patient. You need to have a thorough GCS starting, hourly GCS starting, hourly pupillary starting for the maybe for the next 24 hours. Maybe you need to repeat a CT scan after 6 to 8 hours. How you have to see how the bleed is. Maybe after 24 hours again you need to repeat, and you need to go ahead with a definitive vessel study like CT angiogram or a digital subtraction angiography. Digital subtraction angiography not immediately, maybe after 48 hours we can do, but immediately CT angiogram can be done to look for what is the source of bleed. So if you don't get anything, probably we have to think in terms of a mesenchymal bleed. So majority of the time we won't get the reason behind that, but you have to treat it. So treatment options as suggested, these are the 1, 2, 3. We have to prevent raised ICP and secondary brain damage. So that's the most important thing. Like in trauma, when you discuss regarding head injury, the same thing happens here also. So what are the things that you need to prevent? Hypotension. Hypertension definitely you are treating, but you should not cause hypotension also, because again cerebral perfusion will come down. Then you need to prevent hypoxia, hypothermia, then hyperpyrexia, then what else? Coagulation, definitely we have to look in for. That is the next biggest challenge, that if the patient is already on some anticoagulants, the patient is already on aspirin, warfarin, so we need to think of reversing these agents by giving, it's a life-threatening hemorrhage. So here you need to use your FFP and your vitamin K. So the patient was on warfarin and he's coming with a subarachnoid hemorrhage, definitely you need to, this is one of the, when all patient, we don't go for reversal, but this is a life-threatening bleed that this patient has had. So if the patient, depending upon what the patient is on, you need to give the reversal agent. If the patient was on apixaban, you have to go with that reversal agent, dabigatran, uridarisumab, all those agents you should remember. Aspirin as such, you don't have any major reversal agents, but usually 5 to 6 days it will take the effect of aspirin to wean off. So that we cannot do anything. We just need to wait and watch. So this is in a nutshell. And what happened to this patient?
Patient re-look CT was taken and the bleeding is not increasing. So he's planned for discharge today.
Discharge today. So probably venous bleed, what we are suspecting, would have happened to this patient. So our nutshell, a patient coming with headache, one of the worst differential diagnoses, one of the most important differential diagnoses, what we need to consider is the subarachnoid hemorrhage. So the patient had a very classical, so we didn't miss the patient. But whenever the patient is coming, always keep this thing as your differential diagnosis. Remember the risk factors and the severity, and more importantly, the onset type. If it is an acute onset with any of the features of raised ICP, always think it is not a big investigation that you need to do. You do a simple CT scan brain, you will be able to, it's a simple investigation and you can easily understand what is a subarachnoid hemorrhage. You need not have an experienced radiologist to look for and to diagnose a subarachnoid hemorrhage. A junior person itself can just look into CT and say it is a subarachnoid hemorrhage. So that you should keep in your mind. And when the patient is diagnosed, the primary A, B, C, D things, and when you are planning for intubation, so that is the another challenge that you might have. So we need to use an agent that will not cause a hypertension, further bleeding, and it should not cause a significant hypotension also. And you can give an agent which can have decrease in the brain activity also, so which has got an anti-seizure property. When you ask me, the ideal agent would have been propofol, but the problem with propofol, the propofol can cause significant hypotension. So we need to maybe mix it with another agent, maybe half dose of propofol, maybe with an etomidate, or etomidate it's safe enough, but it will not have any decrease in the brain. Anti-seizure properties are not there. Instead, it can have seizure property. It can cause myoclonus. So maybe propofol is an ideal agent if you have got significant blood pressure, but if you are not planning, the patient is already in hypotension, that will not be an ideal agent. And again, ketamine, maybe what we can do, we think that ketamine will raise ICP, that's all theoretical, but you can give a mixture of the BP have like something like 130-80. You don't want a hypotension caused by propofol, you want some hemodynamic stability also. So what you can use is ketofol. You take half of ketamine, half of propofol induction agents, and you can give to that patient. So that is a way, but you have to be very, very, very clear. So every emergency physician or an intensivist or an SHS, they will have a preferred agent. And why you wanted to mix it like this? Because one side effect can be decreased, and other thing, its superior effect also will be delivered to the patient also. So it all depends. You have to select your agent, and again, while doing scopy, there can be sudden bradycardia. So that is one of the risk factors that you need to remember. Maybe sometimes you need to give a dose of atropine also, very rarely, or lignocaine also. So that all, if you're doing a smooth intubation in the ED, that we are giving an adequate paralytic agent and you are using a good induction agent, these issues will not happen. We have not seen in any of these years, but subarachnoid hemorrhage, generally they will come with a preserved GCS. Usually they will come with a preserved GCS, and very small group of patients, if they go into the ventricle and causing obstruction and hydrocephalus, then they will start developing the symptoms. Okay. Fine. Thank you.
Thank you.